Hello, and welcome to our Robert Wood Johnson Foundation First Friday Google Hangout on From Preparation to Recovery, a focus on health. I'm Susan Denser, Senior Policy Advisor to the Robert Wood Johnson Foundation, serving as your moderator today. Today we'll be talking about how communities can incorporate health and healthcare into disaster planning and response. As we'll hear, the Robert Wood Johnson Foundation has had a long-standing focus on public health and emergency and disaster preparedness. And now its efforts to work with partners to build a culture of health in America includes working to build that culture into communities before disaster strikes and to continue in that vein during the recovery phase. We hope that as our discussion proceeds today that you'll tweet us your questions. The hashtag is on your screen. As you see, it's hashtag RWJF1STFRI, as in First Friday. So please go ahead and tweet us your questions as our conversation today proceeds. We have three terrific speakers today, so let me introduce them to you now. First, we're delighted to have with us Paul Keenert, who's Director of the Bridging Health and Healthcare Portfolio at the Robert Wood Johnson Foundation. He's also a former public health official from Illinois. We're delighted also to have with us Reed Tuckson, who's managing partner of Tuckson Health Connections and chair of the Committee on Post-Disaster Recovery of the community's public health, medical, and social services. That committee produced the IOM, the Institute of Medicine report, Healthy, Resilient, and Sustainable Communities After Disasters, that we'll be talking about today. And finally, we're also very happy to have with us Jennifer Leaf-Lang, who's Senior Vice President of Partners in Care. That's an affiliate of the Visiting Nurse Service of New York, which undertook some extraordinary activities to respond to Hurricane Sandy 3 years ago. We'll be hearing about those as well as about Partners' other work to build a culture of health going forward and be ready for when the next disaster strikes. We're going to start today with you, Paul. Give us a sense of the Foundation's support, first of all, for the Institute of Medicine report, why it chose to support that report. Talk a bit, if you would, about the related activities that the Foundation has long been engaged in around emergency preparedness and response. And let's link all those back to the focus now at the Foundation on building a culture of health.
Well, thank you very much, Susan, and good afternoon, everyone. Just at the top, I would like to acknowledge that given the events this week in San Bernardino and given the topic that we're talking about, I just want to say that our hearts, our thoughts are with Trudy Raimondo and her staff at the San Bernardino Health Department, as well as all the members of the community of San Bernardino. We certainly hope that a prevention agenda can help all of us in our country move forward and stop these senseless acts of violence. But we know now we're really in a recovery stage in that community and across the country. So many of the issues that we're talking about today do have immediate relevance in San Bernardino and across the country. So with that said, let me, as you asked, provide a little bit of context in terms of the Foundation's support for this report and the area of disaster preparedness and response more broadly. For many, many years, the Foundation has been very committed to disaster response and preparedness, certainly going back at least to Katrina, to Haiti, to most recently Sandy, in terms of providing immediate relief and disaster response. And then most recently we've been making a number of investments around preparedness, public health and healthcare preparedness for disasters and disaster planning. As you said, Susan, this is so central to the whole notion of building a culture of health, this idea that we have, this vision that we have, that all of us in our diverse society are able to live the healthiest lives possible. And we know that that's not going to be possible at all for anyone in the face of disaster unless we are prepared. We also know that planning for disaster response brings us right into the areas of action that we think are key for building a culture of health. So building and creating a shared value of health for all in our community, working across all of the various sectors that need to be engaged for disaster planning, working to build a healthy community infrastructure for disaster preparedness, and then, of course, working to create the connections between healthcare, public health, and community-based organizations. All are key for disaster preparedness, and all are key for building a culture of health, improving our health for all in our communities. So just 3 areas very quickly that the foundation is making current investments in terms of disaster preparedness. First, we do have a set of investments in follow-up and recovery for the state of New Jersey from Sandy. And just to mention very quickly that we've invested with our partners at Rutgers University to use the tools of health impact assessment to do disaster recovery planning. We're working in 2 specific communities in New Jersey, Hoboken and Little Egg Harbor, on a couple of specific projects, and then really trying to bring that technology of health impact assessment into disaster planning. We're working nationally with FEMA and other partners on that. A second investment that we have ongoing right now is the National Health Security Preparedness Index. And this is a web-based tool that can be found at nhspi.org. And there you'll see that this is a measurement tool for getting a comprehensive picture of how prepared we are in our country and state by state for responding to disasters of all types. And then thirdly, right now we are making a number of investments in community resilience. Some of these investments, like our work with UCLA and the Los Angeles County Health Department, are focused specifically on disaster preparedness and resilience. And we're also working in the areas in a number of communities across the country around adverse childhood experiences and working with community coalitions to build that ability for families, for individuals and communities to bounce back from things like trauma as well as disasters. So in this area, we are planning to make a number of investments in the coming year, have a number of funding opportunities for folks. So I would really encourage people to go to our website at rwjf.org and subscribe to those funding alerts so that they can become aware of opportunities for grants coming up in 2016 around community and disaster resilience. Thanks.
Terrific. Thank you so much, Paul. And we should mention that we did a Google Hangout last January on the National Health Security Preparedness Index. And those who want to watch it could go to the Robert Wood Johnson Foundation YouTube website on our the YouTube channel. Google that index, and you can watch the Google Hangout that we did back in January devoted expressly to that topic. With that, Reed Tuckson, I'd like to turn to you. As I mentioned, you led the IOM committee that produced the report that we're going to be talking about now. Tell us what the highlights of that report were, and how does the report offer some guidance to communities on how to incorporate a focus on health into their disaster planning and anticipation of recovery efforts?
Well, thank you very much. And a lot of our report is very much aligned with what we just heard from Paul. But it ought to seem obvious, but it isn't obvious in America, that we spend billions of dollars in planning and recovering from disasters. But what we do not do very often, in fact, very rarely, do we actually look at creating healthier communities as we are rebuilding from disasters. In fact, as we all know, those of us who are in the public health world, the health of America is suboptimal as baseline. So if we are not as healthy as we ought to be, and if our communities are not, the last thing we would want to do is to rebuild communities exactly like they were before. We need to get ahead of the curve and then be able to use the billions of dollars that are spent, unfortunately, every year in recovery to create healthier communities, not the same communities that we existed before. That would be short-sighted. And so what we argue for and what we were able to propose is a strategy for how to incorporate overall healthiness into the disaster planning and recovery area by starting, number one, as Paul indicated, with visioning. There needs to be a pre-existing vision of what is a healthy community. And every community should have that as a baseline. Then be able to do an assessment of the overall quality of health. What are the strengths, but more importantly, what are the deficiencies? And then be able to plan and then implement the basis of those plans. The opportunities presented by disasters gives us a chance to highlight 3 quick recommendations out of 12 that we've made. Number one, beginning with this idea of developing this healthy vision of a community and then make that vision known to all of the participants across the landscape of disaster recovery. That means those that are dealing with the built environment as well as the social environment. Our city officials, our elected officials, federal officials, all of them need to be able to come together around a pre-existing plan for what looks like a healthy community for that particular community. We advocate in reference to this a health in all policies approach, which is now becoming a much more well understood concept that links systematically the idea of what are the health consequences of every decision that is made. Number two is then to take this idea of this visioning and secondly integrate it into the considerations for the recovery decision-making process. The National Disaster Recovery Framework is a very, very important organizing document that brings together all of the federal resources from multiple agencies, especially FEMA and 5 other agencies. And it creates this framework for how pre-disaster recovery planning should occur and how it ought to occur once the disaster occurs. What we are being able to say is we need to integrate now all of these players around a concept of a healthy community. And then third and last, and very important, is that the federal government officials responsible for that disaster recovery framework need to do a much better job of making that process understandable to the multiple stakeholders who should be and need to be engaged in the process of using the recovery effort as a way to create healthier communities. It is a very complex process, very user unfriendly, particularly when a crisis exists. And so we are calling for a simplification and training so that health-related stakeholders can participate more effectively in the process.
Thank you so much, Reed. And just to stay on you for a moment, as the report notes, communities are very infrequently aware that there are dollars attached to these response efforts that give them the ability to plan for health in advance of disasters. Is that not right?
That is an essential point, Susan, and there are dollars available on both ends of the spectrum. Number one, there are lots of dollars built into this National Disaster Recovery Framework for pre-disaster planning. Those activities are going on all across the country. Unfortunately, what doesn't happen is that the natural work that health people do for creating a plan for a healthy community are not integrating those together or taking advantage of those resources. And then quickly, secondly, on the disaster response activity, there are, as I said, we spend billions in responding, building roads, creating new highways, opportunity to deal with grocery stores. All of that apparatus that occurs after a disaster needs to also, those resources and dollars can be clearly leveraged and better used as in the context of creating a healthier community. So on both ends of the dyad, there are dollars, and the public health people need to be aware of these sources of funding.
Great. Well, thank you so much. So Jennifer, let's go to you next. As I mentioned, you at Visiting Nurse Service of New York and your affiliate, the one you're with, which is Partners in Care, had an extraordinary response in the wake of Hurricane Sandy just 3 years ago. But you've also used that to look forward now and decide what needs to be done also to build a culture of health in the community in advance of the next disaster. Tell us about that.
Sure. So let me start by saying that the Visiting Nurse Service of New York is certainly no stranger to responding to emergencies that occur in New York. We've been out there in the community for years. So when we first heard of the impending storm, we immediately sprung into action. One of the first things that we did is identify patients that were in evacuation zones. And we contacted those patients to confirm whether or not they would be evacuating. And as we know, not everyone chooses to leave their home, even though they're instructed to do so or urged to do so. So for those who were deciding to remain at home, we went through checklists with them to make sure they had the necessary supplies available and had a support structure to ensure their safety. We also had nurses and rehab therapists make early visits to patients, knowing that there was a possibility they wouldn't be able to reach those patients during the storm. At the Visiting Nurse Service in New York and Partners in Care, we use a prioritization system of our patients, where priority 1 patients are the ones who are most vulnerable and at greatest risk. And that's usually considered under chronic medical conditions, existing support structure, and whatever risks might be occurring in the community that they reside in. And so once we identified which patients were in those categories, we reached out to those patients, made sure again that they had any necessary supplies. And for those patients who were getting home health aid service through Partners in Care, we let aides know that there was a strong possibility that they may have to stay with patients for extended periods of time, potentially several days, which did in fact occur, and we prepared families of that as well. We encouraged staff to charge their phones. We implemented our emergency response activation system. We had staff come into Manhattan, myself included, staying at the hotel across the street, so that we could be in the office to act as a command center and coordinate care as necessary. We ensured that we knew where all of the staff were so that if people had to reach patients, we were able to get in contact with them. During the storm and the weeks after, we had over 5,000 nurses, rehab specialists, home health aides, making visits to patients. During the storm, you had nurses and aides going by foot, riding bicycles, walking over bridges, trudging through water, doing whatever they could do to get the best care to the patients that were most vulnerable during that time. And then we were knocking door to door to try and get in contact with patients who had no cell phone service and we didn't know what happened to them. And we focused on areas that were devastated the most, areas like the Rockaways and Staten Island, Coney Island, Red Hook, and Lower Manhattan. And we were trying to identify what kinds of issues they might be under at that moment, whether they needed additional supplies, if there were behavioral and mental health issues, and then we sprung into action to respond. One of the great things about the Visiting Nurse Service of New York is that we are a part of the community. We're out there every day, so we have relationships with pharmacies, with other healthcare vendors. So during Sandy, we leveraged those relationships to really help to coordinate care, get prescriptions filled, get medical responses to people that had immediate needs, and that really worked in our favor so that we could respond well in the community. Now, like so many other organizations, we faced monumental challenges when the storm struck. We had staff from across program lines definitely having challenges meeting their patient needs. And we identified that there were health and mental services that were needed in those areas by those impacted most by the storm. And so, like I said, after going door to door and understanding what those needs were, we really understood that there was an unmet need for following the storm. And that's where we leveraged some of our internal strengths. So really, this whole new at-risk population was created because of Sandy, and it had a dramatic impact on the way that we wanted to approach care on a go-forward basis. So one of the things that we did was apply for grant funding through the American Red Cross, and we were awarded that funding. And so over an 18-month period in areas like Brooklyn, the Rockaway, Staten Island, and Nassau County, the Population Health Management Group and the Community Mental Health Program coordinated an expert crisis team to provide individualized care to those who needed it. And some of that care included things like crisis counseling, basic support and education, and group counseling. And because the community mental health team worked in conjunction with population health management, these residents also had calls and visits from registered nurses who were able to reconnect post-Sandy victims with primary health services that were really so necessary at the time. And by providing that outreach, we really worked to try and keep families and communities intact at that time and identify preventative measures so that we could help individuals and communities prevent these unnecessary acute illnesses going forward.
Great. And Jennifer, just quickly, what are you doing now? It's 3 years after Sandy. We know much of the area is still in recovery mode, but what are you doing now to approach the health of the population in anticipation potentially of the next disaster?
So there are a number of things. I think Dr. Tuckson pointed out something that was extremely critical as we move forward. It's not necessarily always about responding to those chronic conditions as they exist, but primary prevention is really necessary in the community. And we do a lot of that work with our population health management to identify the needs in the community and provide the necessary tools to keep people healthy so that when things like this happen, you're not necessarily dealing with those chronic conditions. And then again, we always revisit our emergency planning to make sure that we have the necessary tools in place so that should something happen, we know what needs to happen and we can implement it quickly and really be a pioneer in the community.
Great. Well, thanks to all three of you. So what we've heard, first of all, from Paul, is that the entire focus on thinking about how to build health in advance of disasters and respond with the focus on health after disasters really is at one with the Foundation's approach on the culture of health. And he mentioned the work underway now to help specific communities in New Jersey with those health impact assessments so they can figure out exactly how to be in a better position to respond, that heaven forbid when the next disaster hits. We heard from Reed that a strategy was put forward and suggested by the Institute of Medicine report, beginning with the vision of communities, envisioning what our health status will be once we get to the optimal level, undertaking again a health in all policies approach to that, conducting assessments to figure out how to get there, working in cross-sectoral collaboration, and following the framework of the National Disaster Recovery Framework, as incomprehensible as it may be. Nonetheless, it does pose a plan for communities to think through all of these things. And as Reed mentioned, hopefully the federal government will make that a little bit more clear for people, but there are dollars attached to all of this that communities can avail themselves of. And then finally, we heard from Jennifer about the extraordinary efforts, again, that the BNSNY and Partners in Care undertook to get ready for the storm and how they are now focusing on the population health approach after the storm to get ready for the next one. So, Paul, did you just want to say a bit more about these health impact assessments in particular? I know that those communities that you mentioned in New Jersey, which were hard hit by flooding, really are trying to think through in the future not just how they protect themselves from flooding, but how they can, in effect, also benefit from the standpoint of community health.
Sure, thanks, Susan. I think that what I wanted to say is really complementary to what Jennifer was saying in terms of what healthcare providers can do proactively to kind of position and work with families and individuals that they're working with around their services. That we also need to think about this as an opportunity on the community level to think about how, as Dr. Tuckson was saying, how we can use these resources that come to communities after a disaster to really promote health in terms of the rebuilding effort. So let me give you a couple of examples from New Jersey. The Hoboken project is focused specifically on stormwater management. So Hoboken was one of the communities that was really inundated by Sandy, had much of the community under 7 feet of water. And as part of that, when you have that kind of storm and the backup and the mixing of stormwater with sewage, everyone can imagine the kinds of health problems that can create. So the Health Impact Project is looking at how to plan for stormwater management and redesign those systems to minimize that kind of mixing going forward, and really use communities' design efforts to help in that management and in flooding prevention. So that's one example. The other with Little Egg Harbor is focused on housing. And again, this was a community that was literally inundated, many houses flooded, and the recovery funds now are being planned for purchasing some of the housing that's in the most low-lying areas of the community, and actually taking those houses out of housing and helping people relocate. So as we can imagine, that kind of policy, that kind of implementation will have all kinds of implications, health as well as financial and other implications for the families involved and for the community as a whole. And so in both of these cases, we're using the health impact methodology, which is a standardized methodology to gather information, to get a lot of stakeholder input into these decisions, and be able to forecast, if you will, what the health impacts, both physical, mental, social impacts there will be as a result of plans or policies. One of the things, and I think we touched on this before, is the lesson being learned from this is already that trying to do this kind of planning after a disaster is really, really difficult. And what we're looking at, and specifically the colleagues at Rutgers in the New Jersey Health Impact Collaborative, are working closely with FEMA and with other partners on the national level to position these health impact assessment techniques and to start using some of the pre-event planning funds that Dr. Tuckson was talking about to do this kind of work in advance, so that health impacts are part of the planning for any kind of disaster mitigation that happens after a disaster.
And to state the obvious, the health impact here is moving people out of harm's way, at least in that one case. We also hear about other communities that have decided to dedicate flood zone properties to parks, for example, to create a buffer zone, which could be used to benefit recreation and other things when there isn't a flood, obviously, but also protect people in the event of a flood, correct?
That's right. I think that there are many opportunities to use these plans and use the changes in the built environment to foster health all the time for the community, as well as position the community in a better way for any future disasters.
Reed, I know the IOM report had also some examples of communities that have done similar things to build health into planning after disaster recovery, but again in anticipation of future disasters. Can you cite some examples that are relevant?
Let me give two very quick ones. On the pre-disaster planning side, we were very impressed with some work that comes from Thurston County in the great state of Washington. They call their initiative Thurston Thrives. And what they were able to do was to create this idea of a community-wide vision and then unite a wide array of service providers, the clinical care delivery system, community design and urban planning people, people that are focused on creating a vibrant economy, the education system, the food system, and the housing system, and pulling all of those together into a coordinated, multifaceted plan for how their community can thrive. It is easy to see, Susan, as you set out the question, and as we've just heard, that you can take that kind of vision, and then when there's a disaster or a crisis, marry it with the post-disaster planning process. On the post-disaster recovery process, we were impressed by Galveston, Texas, who we all may remember the terrible floods of 2008, where the city's health and safety network were essentially wiped out. What they were able to do was to assemble a very clear evidence-based list of what their existing challenges are, then be able to take an inventory of all of their community resources, mobilize all of those resources to address their challenges, and then were able to partner with decision makers to incorporate these ideas from the health side into the overall effort to recover from the disaster. So I think these are two great examples. But again, I think that the theme of this call is really emphasizing it is very difficult to do the healthy community planning activity in the midst of the crisis. You need to have something in place on the front end and then establish those relationships between the health-focused people and the disaster recovery people, so there is a relationship that can mature and function when the crisis occurs.
Thank you so much, Reed. And once again, I want to remind our audience you can tweet us your questions at hashtag RWJF1STFry, as in First Friday. So Jennifer, just on that point that Reed made about having relationships and connecting across sectors to collaborate, I know that in the wake of Sandy, one important change has been that Visiting Nurse Service of New York is one of the organizations now that is on region-wide emergency planning phone calls to get ready for coming disasters. How do you feel that other relationships across sectors have solidified now, such that you all will be in an even better position to respond next time around?
Well, I think that was something that was absolutely necessary at the time, because we are out there in the community every day, and we probably know the communities better than most people because we're working with those patients constantly. We know the barriers to care that exist there. We work on interventions there to try and get people the care they need. I think one of the things that came out of that grant funding provided by American Red Cross is we really were able to gain buy-in from other agencies within the community to respond to some of those barriers that exist, and those relationships continued moving forward. So for people that had environmental concerns, we were working with the housing agency to try and get people necessary shelter. We were working with different pharmacies in the area to get people medications that were necessary. And I think one of the big things that comes out of events like this is quite often there's a stigma related to the mental health concerns that exist, and people are not sure about where to seek care and don't want to because of the stigma that's related to it. And leveraging some of the community leaders really helped people to get on board. We found that there were people at that point in time that were either uninsured or underinsured, and working with others in the community, we were able to get them insured and get them the care they need. So I think sometimes, unfortunately, it takes a large-scale event to really understand how big everyone's role and impact can be. And I think you can leverage that to move forward and make sure that those relationships continue to put things in place, affect policy changes, and that's very important.
Great. Well, thank you. Well, we have a question that has come in from Mike Anderson, who's the Chief Medical Officer of University Hospitals. He writes and asks Paul, what opportunities exist in the pediatric medical home space to increase resilience in children? Paul, you mentioned the Foundation's focus on those adverse childhood experiences in particular. What do we know about a pediatric medical home approach and the role it could take on in shoring up the health of children, even in advance of disasters or other emergencies?
Sure. Well, I think this is so important because, again, we're looking at opportunities here that can touch children and families in their day-to-day lives right now, as well as helping families and communities prepare for disasters. And we know in the aftermath of disasters that oftentimes children in particular have a significant emotional and behavioral, sometimes certainly emotional results from the disaster and impact from the disaster. So I think what the medical homes can do is, first of all, I think we would be encouraging folks in pediatric practices to be using the screening tools that are now being made available through the American Academy of Pediatrics around understanding their patients' exposure to adverse childhood experiences, and then linking those children and their families with needed services, whether those are social services or behavioral mental health services, educational services, to support them in dealing with the adverse experiences that they have had. Last thing I will say is that this really gives an opportunity for those in pediatric practice to reach outside of their clinical walls and make connections, as so many pediatrics professionals do, with schools, with community organizations, and again, really fostering family and community involvement in supporting the health and well-being of our children. Those things that are done now will help prepare those same children, those same families and communities for a disaster situation.
Reed, can you build on that?
Yeah, I think we were excited when we looked at this report and realized that one of the great opportunities we have in moving this field forward is the change in reimbursement and in the organization of healthcare delivery services. So as the health system is so often impacted by the disaster, let's rebuild the health system consistent with the opportunities for value-based reimbursement, which emphasizes, as we've just heard, this opportunity for the clinical system to be in close partnership with the public health system. If we're going to have the patient-centered medical home for kids, it implies very explicitly that we are going to need to have a relationship between the public health system and the clinical medicine system in a way that gives the clinical people the opportunity not only to provide best quality care, but also to be reimbursed for value. And so we think this is very exciting. I would add that people should therefore be excited about the ASTO Collaborative, which is integrating primary care and public health. It is a very specific initiative to give better tools and training and knowledge to really make that synergy work between those that are doing patient-centered medical homes, ACOs and those things, and public health departments. This is a very, very important opportunity.
We have another question that has come in from Claudette on Google+. He asks, would community health take the lead in disaster management? Flooding and blizzards require different approaches, for example. So I guess that really poses the question, can one branch of the multiple stakeholders here take the lead, or who does take the lead in these instances? Reed, why don't you address that?
One of the things here, though, and that's what comes and why it's so important for people to be familiar with this National Disaster Recovery Framework, because that pretty much lays out the chain of command and the order of things. And so it would be very difficult for the health people to become the primary drivers of the recovery process. That would be very difficult because the systems are pretty well ingrained. That being said, I think that the questioner is spot on by saying that whenever they're having any of these meetings on the disaster recovery effort, the public health leadership needs to be at the table from day one. And the people from the public health department that should be at the table from day one are not just the emergency public health team, because what we were shocked to find is that in most of the cases of the testimony we heard, the public health emergency people are not themselves connected to the long-term community health planning and strategic design people. So there's a disconnect even in the public health department. But the thesis of the question is great. They should be at the table, but it'd be very difficult given the processes and the flow of dollars that currently exist for the health people to take over the fundamental lead.
Well, that's a great transition to some closing questions that we will move to now as we approach the end of our People Hangout today. And thinking about communities, and those, particularly those in communities who are focused on those long-term health issues, as you said, Reed, what's the roadmap for them if they want to get involved in disaster planning? What should be a first step that they should take in order to forge the connections that we've been talking about as being so necessary? And are there any toolkits or any other important resources that they should be aware of?
Two things they should do right away. Number one, download quickly the IOM report called Healthy, Resilient, and Sustainable Communities After Disasters. That will give you a really fast start on what to do. Number two, I would then call my local government officials, especially probably the city administrator, the county administrator's office, and find out who the designated lead is for your community, and drive yourself over and have a meeting and say, here we are, we're now prepared to integrate on the pre-disaster planning side our resources together, forge efficient and effective working relationships, and then be prepared to handle what happens after the terrible events of disasters actually when they occur.
Great, thank you. Jennifer, similar question to you. What should organizations like Visiting Nurse Service of New York, those engaged in actual hands-on care delivery in the community, or Partners in Care, again engaged in home health, what should they do to be part of this entire set of preparation efforts and really to build health into those preparation efforts?
I think one of the most important things that agencies need to do is really build relationships with others within the community. One of the strengths that the Visiting Nurse Service of New York has is that we do have a very good relationship with the New York State Department of Health. We have good relationships with the housing agencies because we provide services in some of those naturally occurring retirement communities. And so we have links to other agencies so that we have leverage should something occur and we need to call out other resources. So it's very important not to stay in your own niche and really reach out and understand what resources are available in the community and what could be beneficial to your patient should something happen, or even on a day-to-day basis.
And Paul, we'll turn back to you. A sense, can you give our audience a sense of what resources you're aware of that they should be available, and some advice on first steps to really get into the conversation about health impact assessments or health in all policies, or otherwise getting ready for the next disasters and taking those opportunities to build health back into the community?
Absolutely. Well, I will just underscore what my two colleagues have said already, and that is really the importance of getting to the disaster preparedness and response table before the disaster strikes. So getting into those conversations, building those relationships now. As Dr. Tuckson said, downloading that report from the IOM website, a huge resource. There are also many resources at FEMA.gov and CDC.gov in terms of disaster preparedness and response. And then lastly, again, I think just kind of looking at what really happens in response to actual disasters. We've talked a bit about Sandy. We've learned so many lessons from that, and we're going to be learning many lessons, unfortunately, from San Bernardino. But I know the folks in San Bernardino are and have been really working on tremendous community improvement planning opportunities. And so I would expect that we'll see a lot of resilience from that community going forward in the days and months ahead.
and a very hopeful note to end on amid this terrible tragedy. Well, that is unfortunately all the time we have for this discussion. I want to very much thank Paul Keenert, Reed Tuckson, and Jennifer Leek-Lang for being with us on this Hangout today, and thanks to all of you who joined us. Thanks so much for joining us on this first Friday on Health. Have a great day.